Okay, I think that we'll probably get started. We've got a good number of people trickling in here. Thanks to everyone who came to be here today. My name is Jill Goobie. I'm one of the respirologists in the Division of Respiratory Medicine here, and also hold an adjunct instructor position at the University of Pittsburgh. And today I'm going to be talking about climate change impacts on respiratory health. So really central to any discussion about the environment and environmental influences on health is an understanding of the concept of place and how much importance that plays in the health and well-being of our patients. And with that, I think it's really important for me to acknowledge with gratitude that I live, work, and play on the ancestral and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. These are my disclosures, none of which should impact the discussion today. And the objectives are first to review the impact of climate change on respiratory health from the perspective of air pollution impacts, extreme heat, water impacts, pollen, and natural disasters. I then want to discuss healthcare system costs and adaptations to climate change, highlight some disparities in climate change health impacts, and then discuss strategies for mitigation of climate change health harms. So first, I want to give you a bit of a framework of how to think about our changing environment and how that may impact patients with respiratory disease. This was a figure produced by Kirsty Eby and colleagues in 2017 that was supported by the US Centers for Disease Control that I think provides a really great framework for thinking about the human health impacts of climate change. In the center here, we've got the four kind of main components of environmental change in the face of climate change, including rising.
I can't hear you.
You can't hear us in the room? Are people online able to hear?
Yeah, I can hear you just fine.
Okay, great. Thank you so much. Okay, so the main four kind of environmental impacts are rising temperatures, more extreme weather, rising sea levels, and increasing CO2 levels. And these have downstream impacts on the experience environment, including changes in air pollution, vector ecology, allergens, water quality impacts, water and food supply impacts, environmental degradation, extreme heat, and severe weather. And you can see that in this framework, there's a bunch of different various health outcomes, not specific to respiratory diseases. But what I want you to take from this is that you can apply this framework to really any disease group of interest, whether it be respiratory disease or outside of respiratory disease. And that's exactly what we've done. So Grace Kim, one of the R2s in internal medicine, has been working with me on this review manuscript looking at the impact, potential and established impacts of climate change on patients with interstitial lung disease. And so we've adapted this framework to really think about that within the context of this highly vulnerable population. So you can see those main environmental factors, in the center, and then the specific experience environmental results. And then we've gone through how that may impact a specifically vulnerable population with established evidence and then postulated results in this group. So you can take this framework and apply it to whatever disease group of interest you might have. So I want to talk first and focus on air pollution impacts because there's a strong intersection between air pollution and climate change, particularly as it relates to wildfire smoke exposure, but also ozone exposure and other pollutants, which are often increased in generation in the setting of extreme heat. So our sources of air pollution are changing over time. The primary original sources that we tend to think about are from industry, transportation, and agriculture, but increasingly we're seeing climate-related burdens of pollution, particularly biomass sources such as from wildfires, particularly in the Pacific Northwest. That's a significant contributor. And then there's criteria air pollutants. These are US criteria air pollutants. In Canada, we just don't specifically regulate carbon monoxide and nitrogen dioxide. And then you've got particulate matter 10, which is particles less than 10 10 micrometers in diameter, and 2.5, which is less than 2.5 micrometers in diameter. So the top four are gaseous pollutants. They exist in the gas phase, whereas the bottom two are particles, so they're solid phase pollutants and reflect any chemical that exists below that size that is in a solid state form in the air. So PM 2.5 is the one that we think about having the most human health impacts, and it's particles with a diameter of 2.5 micrometers or less, which is about 1/40th of the width of a human hair. And as I mentioned, particulate matter can be comprised of multiple different components that come from different sources. So when I study PM 2.5, I use satellite-derived hybrid models that use ground-based measurements combined with satellite-derived measures of pollution and give you resolved estimates of these different constituents. And we can break it down into these different constituents that are sourced from different emission types. So we know that sulfate is largely related to industrial processes like steel and coal. Nitrate is largely fossil fuel combustion related. Ammonium is largely agriculture, but also industry related. And we've got other constituent components listed here as well. And particulate matter, depending on its size, deposits in different parts of the respiratory tract. So your large particles, your PM10, is typically going to deposit in the upper respiratory tract and large airways, whereas the PM 2.5, those smaller fine particulate matter, can remain airborne all the way through the airways and transit into the alveoli, where depending on that chemical composition, it may be able to diffuse into the bloodstream, and that is how it's postulated to exert its systemic effects. And then you've got very small particles like the ultrafine particles, which are less than 0.1 micrometers in diameter, that can really deposit anywhere in the airways because they've got variable dispersion characteristics. But the major message to convey to you is that PM 2.5 pollution is a massive global health problem. Looking on the panel on the left, as your PM 2.5 levels increase, your hazard ratio for all-cause mortality increases quite dramatically. So compared to someone who lives in an area where the annual average PM 2.5 is like 0 to 5 microgram per meter cube, someone who lives in an area where that annual average is 20 will have a 20% increased risk of all-cause death. And the cause-specific mortality burden is largely borne by cardiovascular and respiratory diseases, including lower respiratory tract infection, ischemic heart disease, lung cancer, COPD, and stroke. The World Health Organization reset their annual average air quality standard to less than 5 microgram per meter cube of PM 2.5. And 99% of the world's population does not achieve that. We don't achieve it here in Vancouver, even though generally we have exceptional air quality. And about 9 million premature deaths per year are estimated to be directly attributable to PM 2.5 exposures. Mike Brower, who is a professor at the University of British Columbia, led this report in Lancet in 2024, where they looked at the they looked at the risk factors for global disability adjusted life years lost, and they looked at all kinds of health risk factors, and they found that in 2000 and again in 2021, that particulate matter pollution remained the #1 risk factor for lost life years. That's above diabetes, that's above high cholesterol, that's above hypertension, all of these other factors that we're commonly talking about, commonly thinking about as being able to be optimized in our patient populations. And we really neglect the fact that everyone is breathing in air all the time. And in many parts of the world, most parts of the world, the air has a potential to have adverse health impacts. And how does this relate to climate change? Well, in the setting of climate change, we see that wildfires are contributing to significant increased burden of particulate matter. That is very relevant to us here in the Pacific Northwest. The US, this is US data, but it can be extrapolated to Canada. What we see is that with regulation over time and decreased amount of pollution from industrial facilities like steel and coal, there was a substantial amount of achievement in reducing PM 2.5 levels. But starting around 2015, we saw that level plateau or even start to increase across the US. And that effect is most pronounced in the Northwest, West, Southwest, and Northern Rockies. And these are areas most impacted by wildfire smoke exposures, which is dragging up that annual average PM2.5 in those regions. So this is a real problem, and we've experienced it here as well and throughout British Columbia. So this is relevant to our patients and to us. And in the face of climate change, we'll see not only an increase in the frequency of wildfires, but also an increase in the length of wildfire seasons. We're currently in this 1.5 degrees Celsius warming above pre-industrial times. Hopefully we won't get to the RCP 8.5 scenario, which is a 4 to 5 degrees Celsius warming. I'm hoping that we're somewhere closer to the 2 to 3 degrees, but we will still see this, and it is something that your patients will ask you about. So I want to talk about the specific. Yeah.
So Vancouver being above the 5. If you take away the week a year when we have bad smoke exposure, what's
our annual average?
Other than that week, yeah.
Probably we are typically in the 6 to 8 microgram per meter cube, which is excellent for an urban city. That's excellent air quality to be maintaining in a high density area. That's partially topography related. So we get a lot of ocean breeze, and it just tends, any smoke that's impacting us locally tends to be pushed into the interior. Yeah. So this is specific to wildfire smoke related PM2.5. So we do know that wildfire smoke PM, so the particulate matter sourced from wildfire smoke, is associated with an increased risk of all-cause mortality, as shown on the most leftwards panel. The cardiovascular mortality is also substantially increased with an early inflection point around 40 to 50 microgram per meter cube of like a 3-day average of wildfire smoke PM. But you can see the respiratory mortality curve is quite a bit scarier looking, with an earlier inflection point that suggests an exponential increase in the respiratory risk of mortality in the setting of wildfire smoke exposure. And you can see the x-axis on here actually doesn't go that high. It goes to 60 microgram per meter cube. 2 weekends ago, Grand Fondo weekend, Squamish was sitting around 150 to 200 for a couple of days. So we're not even really capturing that high-end PM exposure portion of this curve. So this is really important to be considering, and your patients will ask. This is some data from Ontario in 2023, and this is a smoke plume that you can see going over the Toronto, Ottawa, and other parts of Ontario, highly populated regions of the country. You can see the plume trajectory there. This was the dates where they had the highest PM2.5 levels that corresponded to wildfire smoke exposures. And what they saw was that their emergency department visits for asthma spiked in the days 1 through 5 following the wildfire smoke exposure peaks. And ischemic heart disease visits spiked in days 5 through 7 following those peaks. So both cardiovascular and respiratory outcomes are impacted, and we see this with individual events. Looking more generally at air pollution, we do know that PM2.5, nitrogen dioxide, and sulfur dioxide are all associated with increased risk of acute exacerbations and hospitalizations in patients with COPD. So the PM2.5 risk ratio here is 1.03, which means for each 10 microgram per meter cube increase in short-term exposures to PM2.5 over like a 3-day lag period, you're looking at a 3% increased risk of COPD hospitalization. So if we're talking about going from 10 PM2.5 level of 10 to a PM2.5 level of 100 over a few days, you might get a 30% increase in COPD hospitalizations when you have those high smoke exposure periods. And that can have a significant healthcare burden. We know that asthma incidence is increased with long-term exposures to PM2.5 and nitrogen dioxide. This is a systematic review and meta-analysis led by Emily Brigham, who's one of our respiratory division of professors at Vancouver General Hospital, and her work demonstrated that each 10 microgram per meter cube increase in annual average PM2.5 is associated with a 7% increased risk of asthma incidence. Similar exposure difference is associated with nitrogen dioxide. And the clinical outcomes in patients with asthma are impacted by pollution. So we see that various pollutants have been well demonstrated to worsen asthma symptoms, number of exacerbations, number of hospitalizations, and to impair lung function in this population. There's an association with lung cancer incidence where you see increased PM2.5 exposures over a year period will increase your lung cancer incidence risk by about 9%, so 10 microgram per meter cube increase. Similar effect size for PM10. And then I wanted to touch on some of the recent work in interstitial lung diseases, which is really interesting in looking at the interaction between genetics and the environment. All disease incidence, well, the vast majority of disease incidence in any condition is going to be related to a combination of genetics and the environment, unless you have a true Mendelian disease or a very pathogenic variant that might be entirely genetically determined. The vast majority are going to be due to that interactive effect. So in this study, they took a whole large population. They used polygenic risk scores to qualify everyone in the population into either low, medium, or high genetic risk. They then took their residential location and they put them into quartiles of pollution exposure. What they found was that individuals at low genetic risk had low likelihood of developing IPF regardless of their exposure. The individuals at high genetic risk had high likelihood of developing IPF regardless of the exposure, although there was probably a trend towards an even higher risk with the highest pollution. But it's this medium genetic risk group, people that maybe carry one or two variants that increase their risk of IPF, that seem to have the most susceptibility to environmental exposures, such that individuals in the medium genetic risk group who have the highest PM2.5 exposures had about double the risk of IPF development than someone at low genetic risk and low exposure. So we need to think about that on a population scale. This is some work from Australia that looked at proximity to roadways, because the closer you live to a road, the higher your point pollution exposures are generally going to be, as well as actual measurements of PM2.5 and nitrogen dioxide exposures. And they found that closer distance to roadways, as well as higher PM2.5 exposures, were both associated with a more rapid decline in diffusion capacity in patients with IPF. This is some of my work from my PhD, looking at PM2.5 influences on clinical outcomes and mortality in patients with fibrotic ILD from across North America. We looked at over 6,600 patients across the University of Pittsburgh site in yellow, 40 sites of the Pulmonary Fibrosis Foundation in blue, and 8 registry sites of the Canadian Registry for Pulmonary Fibrosis in red. And this is projected on a map of PM2.5 annual average levels for the year 2005 across North America. We saw the highest pollution levels in Los Angeles, that's largely traffic related, high levels in Pittsburgh region and that sort of part of the US where there's a lot of industrial pollution historically. But then you can also see that there's these hot spots in northern Quebec and Alaska. These are not industrial hotspots, they're not densely populated urban regions. These are wildfires that occurred that year. And so that gives you an idea of these short bursts of events have enough pollution that they drag up the entire annual average for that region to really substantial levels. And it also reflects how using these satellite-derived measures, we can capture that granularity in these sparsely populated regions that we normally wouldn't capture with ground-based measurements. And what we found was that as the PM2.5 levels increased for this population, that the hazard ratio for all-cause mortality, death or transplant in patients with fibrotic ILDs was increased substantially. So we've got the WHO annual standard. The American Thoracic Society recommends a level less than H. You're probably still protected at that level. But as soon as you go above that, you see a really scary looking inflection of the curve where your risk of mortality increases substantially and rapidly. And I can tell you that much of our population, especially our American population, had long-term PM2.5 levels well above that 12 level. And that hazard ratio is per 1 microgram per meter cube increase in 5-year PM2.5 levels. So that's a very substantial effect, highlighting that this is a highly vulnerable population. And we saw that the human-derived constituents of PM2.5, the sulfate, the ammonium, and the black carbon, were really the constituents that were driving that mortality effect most profoundly. So that's all I'm going to touch on for air pollution for right now. I'm going to move on to talking about extreme heat and how that impacts patients with respiratory disease. So what we do know is that extreme heat events are going to increase in frequency and severity in the face of climate change. The panel on the left comes from the Intergovernmental Panel on Climate Change, or IPCC. And in different future global warming scenarios, you see increasing frequency of a 10-year heat event or a 50-year heat event. So some of you may have been living in BC at the time of the 2021 heat dome. I think that was like a 100-year or maybe even more heat event. So a 50-year event in a high warming scenario where you see 4 degrees Celsius of warming is going to happen 39 to 40 times more frequently. So we have to anticipate this and prepare our health systems for that. The data on heat-related mortality and specific disease impacts is really in the early stages of growing. We're working on expanding that. But this study from epidemiology in 2008 looked at 15 European cities, and they looked at mortality related to a 1 degree Celsius maximal apparent temperature increase in those cities. And they found that there was about a 6 to 7% increase in respiratory mortality, compared with about 2 to 3% all-cause mortality increase and about 2 to 4% increase in cardiovascular mortality. So again, the individuals with respiratory disease are probably some of our more sensitive to these climate alterations. And these are extreme heat event predictions for across Canada, and this is produced by Health Canada. So currently, we're looking at historical 1976 to 2005. That's the frequency. Near future is 2021 to 2050 under low emission scenarios and high emission scenarios. And then the future is 2051 to 2080, getting towards the mid to end of this century. And what you can see in different cities across Canada is that the frequency of these very hot days greater than 30 degrees Celsius and the warm nights greater than 20 degrees Celsius is going to increase significantly, especially in our highly urban cities. Part of the reason, and we'll talk about that a little bit later, is the density in those cities and the heat trapping. You get an urban heat island effect that can increase the amount of heat that's captured in these densely populated areas. And we do see, this is from the 2021 heat wave in BC, and these other lines are comparing the nearby years, 2020, 2018, 2019, and 2022 to the number of deaths recorded per week in 2021. And you can see that there's a very aggressive spike in the number of deaths that occurred right around the time of that heat wave. And these are some of the primary illnesses requiring hospitalization that increased during the heat waves. So there was a 25% increased risk of pneumonia hospitalizations, but you can see the other conditions that were also significantly impacted at that time as well, non-respiratory etiologies. So there's some early data indicating that extreme heat is associated with increased risk of asthma exacerbations. So extreme heat events are associated with about a 7% increased risk of asthma exacerbations based on this meta-analysis. They're also associated with increased COPD mortality. In the setting of an extreme heat event, there's up to about a 16% increased risk of COPD-associated mortality. So I certainly have the experience of admitting patients with COPD to this hospital in the summertime in the peaks of temperature, especially if they're lower income or minoritized individuals that don't have access to air conditioning or other cooling. They may live in a more cramped apartment with minimal airflow. I've had multiple patients describe a very severe sensation of worsening dyspnea and really not being able to catch their breath, worsening accumulation of mucus production. This is something that people do describe, and I've seen it firsthand, and I think that we will start to see this more frequently as time goes on, unfortunately. And in fibrotic ILDs, my area of interest, we don't have any data on this. We're hoping to generate it in the coming years. This is just one mechanistic study. I think this is the only mouse slide that I have. But this took 9-week-old mice that were exposed to either 22 degrees Celsius constant temperature, or they had a 2-hour high intensity exposure to 39.5 degrees Celsius. They then looked at the lung tissue of these mice. They found increased collagen deposition, increased fibrotic area, increased TGF-beta and fibronectin, which are fibrotic mediators. And so that does suggest that the extreme heat exposure was pro-fibrotic, and so certainly something that we need to look at in this highly vulnerable population. And the other piece of data that I'll bring up here is from, this is really the first pollution study that was done in interstitial lung disease, led by my long-term mentor, Carrie Johansson from the University of Calgary. And she looked in a South Korean cohort at the effects of gaseous pollutants, ozone and nitrogen dioxide on acute exacerbation risk in patients with IPF. And the reason I bring it up here is because extreme heat increases the rate of ozone generation. So when you have those really hot days, your ozone levels will spike, and that is strongly associated with increased risk of acute exacerbations in IPF, but also other forms of respiratory disease. So I want to move on to talk about how climate change impacts precipitation and how that may impact our patient populations. So this is also from the IPCC. There are some regions across the globe that will experience increased precipitation in the face of climate change, and some that will experience decreased precipitation and more desertification. So in the peak warming scenarios, you can see the brown areas are more desertification, and the green areas are more precipitation. And so lots of shifts in those dynamics across the globe as the temperatures increase. This is a picture of a dust storm, I think somewhere in like Arizona or somewhere in the US, but that can give you an idea of how scary that can look. And you're breathing these in. These tend to be larger particles at like PM10 range, but that deposits in the upper airways and can be extremely aggravating. And there has been data that has demonstrated that there's a significantly increased risk of emergency department visits for asthma in the 0 to 2 days immediately following one of those major dust storm events. This is a study from Greece that looked at the PM10 levels on some of the islands in Greece, which tend to be very arid and dry in the setting of dust storms. And you can see that these peaks of PM10 levels go extremely high into like the multiple thousands range. The levels of PM10 generally tend to be higher than PM2.5, but certainly not to this range. That's extremely high. And what they see around the time of that peak is they also see an increase in number of people being admitted for COPD, as well as an increased number of presentations to the emergency department for symptoms related to dyspnea. And then thinking about fibrotic ILDs, there's a number of fibrotic ILDs that are related to mold exposure, so particularly hypersensitivity pneumonitis. And in the setting of hurricanes and increased flooding, we may see increase in mold risk, which can contribute to HP development. We also see that organic dust, so that dust that you would see in those dust storms, is also significantly associated with HP risk, but it's also associated with an increased risk of all causes of ILD. I had a patient recently who grew up in Afghanistan and had a significant amount of daily dust storm exposure, and she was diagnosed with anthrosilicosis, so silicosis from inhaling in significant dust particles in her environment. So we may see more environmental pneumoconioses like that as well in the setting of increased frequency of dust storms. I want to touch on pollen briefly. I'm not much of an expert in it, but I'll do my best to explain. So with increasing global temperatures, we see earlier pollen release and longer pollen seasons. There are, I'm just going to bring this up because I think it's really cool and a lot of people haven't heard of this before, but there's a concept called thunderstorm asthma, where extreme weather events can be a trigger for increased pollen release and allergenicity. So essentially what happens is that you have pollen in the air and then you have a big storm that kicks up a whole bunch of dust and pollen more into the air. Then you have lightning that happens as a part of these big storms. And what happens is that pollen particles are often charged. And in the setting of the static electricity in the air, those pollen particles can rupture. And when they rupture and settle back down, the antigenicity and allergenicity of those particles is much more aggravating, and it binds to the receptors in the airway much easier, and it has a significantly increased risk of triggering asthma exacerbations and rhinosinusitis symptoms and other allergic type symptoms. So after big storms, you may actually see peaks in asthma emergency department visits. So that's just a neat little mechanism. There's also increasing evidence that many individuals with COPD are sensitized to pollen and fungi, which is also associated with worse outcomes. So on all of these box plots here, the left panel are healthy controls and the right panel are individuals with COPD. And you can see the level of pollen sensitization on this top row, the level of different house dust mite and cockroach antigens in the middle, and then mold or fungus species on the bottom row. And the individuals who had the fungal predominant sensitization with COPD tend to have the lowest baseline lung function. And they also have a much higher exacerbation frequency. There's also some old data that suggests that pollen exposures may be associated with excess mortality in individuals with COPD. So this is the pollen concentrations of grains per meter cube. And you can see that as the number of pollen grains in the air increases, the hazard ratio for COPD mortality increases. There's also probably some effects on pneumonia mortality as well as cardiovascular disease mortality based on this study. And the last kind of area I want to talk on clinical impacts before we get into the health system stuff is natural disasters. So there's increasing evidence that extreme weather events are associated with increased poor asthma outcomes. So specifically, this systematic review looked at asthma emergency department visits. So in the time surrounding a severe or extreme weather event, there's a 25% increase in asthma emergency department visits, a 19% increased risk of outpatient visits, and a greater than twofold increased risk of asthma-associated mortality. And we need to think about access to care during these extreme weather events. And I think it's very important for all of our health systems to have emergency preparedness plans in place. In respiratory medicine, one of the more vulnerable groups of populations that we have are individuals who are oxygen dependent. 40% up to 40% of ILD patients will be oxygen dependent. We probably see that a little bit less, but certainly there are a large number of our patient population that are oxygen dependent. Following the Fukushima natural disaster with the earthquake and tsunami in 2011, this was one case study where they found that 83 individuals with chronic respiratory diseases on HOMO2 presented to the nearby Ishinomaki hospital, and 20% of those patients had worsening of their underlying respiratory disease or exacerbations that was presumed related to treatment interruption. So we definitely need to think about oxygen access in the context of natural disasters. Now I want to talk about health system costs of climate change. So this is health system costs attributed to wildfire smoke in Australia. And the gray lines here are the smoke-related costs in different years to the Australian healthcare system. And you can see that in the 2019-2020 mega fire season in Australia, if those of you remember it right before the pandemic, they had about 1.9 billion additional costs to their healthcare system in the setting of those fires. So when we see these extreme events, the healthcare costs, not only the burden on our patients, but the cost of the system are very substantial and something that we need to be factoring into our considerations of where we're going to allocate resources and how to implement policies and regulation to try to address this problem. We anticipate that extreme heat events in BC specifically are going to contribute to increased healthcare costs and increased number of deaths. So this is different warming scenarios. So in a medium warming scenario versus a high warming scenario, we can anticipate in the medium scenario about 140 million additional cost per year in that medium warming scenario, whereas up to 260 million additional annual costs in those high scenarios. And the the number of projected heat-related deaths are expected to rise to around over 2,000 in the medium warming and over 5,000 in the high warming scenarios. This is transitioning from heat to thinking about air quality and particularly wildfire smoke exposure. This was a great study in 2024 led by Chris Carlston's group, as well as Kate Johnson, both at UBC. And this is looking at government subsidized HEPA air filter purchase to reduce indoor air pollution for particularly vulnerable groups, in this case, individuals with a diagnosis of asthma. And they found that in most parts of British Columbia, that subsidizing HEPA air qualities for those highly sensitive groups is a cost-effective intervention. So this is the sort of thing that we need to be expanding. We need to do more of these studies to look at the cost effectiveness in vulnerable groups, and we need to also be promoting regulations and policies and legislation that can create a pathway for subsidizing these sorts of interventions for our vulnerable groups. And speaking about vulnerable groups, let's transition into talking about disparities in climate change impacts on respiratory health. This is an old slide taken from the WHO, but the larger message remains the same in that air pollution-related mortality is not equally distributed across the globe. So the higher populated, high industry pollution sources, regions of the globe have the highest burden of pollution-related mortality. You know, we look at China, India, other areas in that region as having the greatest number of deaths attributable to air pollution, but we still see very high numbers in other parts of the world, Russia, US, Brazil, and our numbers, they don't look very high based on this, but those numbers are certainly rising in Canada over time, unfortunately. And this is looking at US neighborhood level disadvantage and racial disparities in PM 2.5 related mortality. But what we do know also preceding this is that individuals who are socioeconomically disadvantaged or minoritized in the US, but in many other parts of the world, experience higher levels of PM 2.5 exposure and other pollutants. But also what we see is that as the pollution levels increase, sorry, I'll get my pointer here. As the pollution levels increase, the hazard ratio for all-cause mortality increases at a similar rate. But individuals in the least disadvantaged group have a much lower hazard ratio for mortality than individuals in the most disadvantaged group. Same for individuals of Black race as compared to non-Black race. So these disparities exist not only in the amount of exposure that disadvantaged individuals experience, but also in the mortality burden experience at the same level of exposure. Thinking about heat, so we do know that there's a ton of heat-related disparity that exists, particularly in urban regions. So this is looking at Baltimore urban heat islands, and this is at the Surface Urban Heat Island Index. So the redder it is, the hotter it is. And this is looking at a percentage of the population that is non-Hispanic Black in these circles that are in the middle of each of these census blocks. And you can see that there tends to be a correlation between greater minoritized population percentage as well as a higher index of heat. Similarly, the number of individuals in that region below the poverty line does also tend to cluster in the regions that are hottest. We see this in Vancouver as well. So the areas of the city that tend to have the lowest income or most minoritized populations are individuals in the downtown east side and this region, as well as some other parts of the city. And what was seen in the June 2021 heat wave was that over 25% of deaths actually occurred in neighborhoods with poorer housing quality, lower income, and lower access to green space. So interventions that can help to modify this risk are contributing to urban greening, where you increase the amount of green infrastructure and green spaces available in these neighborhoods, increase access to cooling, increase access to air conditioning, to allow people to have places where they can escape extreme heat and modify that risk. This is a study from this year looking at the Association of Social and Environmental Neighborhood Level Indices with airways disease prevalence. And what you can see is a social environmental ranking. As you go up, that means you have a greater level of social or environmental disadvantage. And what they found was that as the disadvantage scores increase, that the incidence of asthma and COPD increased significantly as well. And this is work from our current ILD fellow in BC, Dr. Nama Abitsur, that she did when she was at the University of Calgary, looking at the University of California, San Francisco ILD cohort. And she looked at the California Environmental Screen, which is a measure of a combination of environmental disparities as well as socioeconomic disparities. And she found, so the areas that are in red are the areas where there's a greater amount of environmental injustice, and green is more environmental equity. And she found that as the Cal environmental screen score increased, so greater environmental injustice, that patients with IPF had worse baseline forced vital capacity and diffusion capacity of the lung for carbon monoxide. And those are very important prognostic factors in patients with ILD. And this is a busy figure, but I encourage you to look at this. This is a workshop report out of the American Thoracic Society that was just published this year, led by Dan Croft, that I had the pleasure of being a part of this workshop. And it's looking at the impact of climate change on respiratory health and how to address this from a environmental health equity perspective. So thinking about the various components in our society that contribute to greater environmental health disparities and what we can do as a society to promote environmental health equity. So I want to talk lastly about how to mitigate the harmful effects of air pollution, wildfire smoke, and climate change. So I think it's really important for us to be able to talk to our patients about how to understand air quality. We need to empower them to be able to look up air quality, to use their weather apps, to have an air quality app that they can look at the Canadian Air Quality Health Index to determine if the air quality is low, moderate, or high risk, or very high risk, and how they might need to modify their activities. And that's going to depend if they are someone who is considered a vulnerable population, so elderly, pregnant women and fetuses, very young children, and people with underlying cardiopulmonary disease are people who should be considered at higher risk and may need to modify their activities sooner. And then this is just an old slide from 2000 to 2006 saying the areas in BC that reached air quality health index that was greater than or equal to 6, so considered higher risk periods of time. You can see Prince George was highly affected. These numbers are likely significantly higher for the interior at this time. So I think this is probably not reflective of the true state of effects now. And then this is a framework for how to counsel your patients and how to mitigate the risks of wildfire smoke exposure. But this is a occupational health framework of interventions and how to mitigate risk for any type of exposure. So you can apply this framework to any exposure that you might be thinking about. So at the top of that framework is really eliminating the exposure. That is the most effective intervention, but it is not always feasible. So we know that wildfire smoke plumes can travel hundreds, even thousands of kilometers. Relocation has significant cost burden, it has significant stress burden, and it may not be feasible for everyone. So then we talk about engineering controls. So installation of HEPA filters is one of those engineering controls that also comes with a cost. You often need to have multiple HEPA filters installed in your house to actually have full kind of air quality control. There's different qualities of HEPA filters. You really need to think about the area that's being impacted. So there's a lot of considerations there. And the other aspect is that HEPA air filters don't do anything to filter out gaseous pollutants. So they're really only targeting those particles. Administrative controls, so staying indoors when the air quality is really bad, avoiding heavy or prolonged outdoor activity. I can't tell you how many people I had asking me about whether or not they should do the Grand Fondo a couple weekends ago. My answer was no. The reason being is that you're exercising outside for 6 hours at maximal minute ventilation, or however long it takes you, maybe you do it in 3. But you have maximal minute ventilation. You're increasing your total dosage of particles that you're inhaling into your lungs over that period of time. And that's going to take a long time for those particles to come out. We don't know the long-term systemic effects. So if the air quality is really poor, modify your activities. Ideally, you want to do that inside. You have to weigh that communication very delicately, though, because you don't want to make people afraid of going outside. So you have to empower them with the information about how to make that decision healthily. And then masks, that's always a question. Not very effective, not very practical. It may be useful if you have to be outside for a prolonged period of time to wear a well-fitted N95 mask to reduce that particle dose, but it's not practical on masks and over long durations. And this is a theme I've also been trying to highlight, is the impact of different personal interventions. We have to think about the burden that we're putting on the individuals. So the greatest amount of efficacy in addressing issues like air pollution and climate change are going to be through changing policies, regulation, and legislation. That puts the least amount of burden on the individual, and it has the largest societal impact. When we have these HEPA air filter installations, staying indoors, reducing your physical activity, wearing respirators, that has a lot of individual burden and cost. So we really want to be looking upstream to changing these effects. And I think that as healthcare professionals and scientists, we have an important voice in driving our policymakers to act on these issues. And so with that, I want to kind of finish off by saying that we have a lot that we can do to advocate for policy action on air pollution and climate change. I think importantly, we should be talking to our patients about this, listening to their stories, talk to them about how they can mitigate their own personal risks. We can always talk to our elected representatives. You can join community advocacy groups. In that setting, it's often useful to think of yourself as a content expert, but to always make sure that you're enhancing the voices of the patients in the community. You can join professional advocacy groups. I'm a part of the American Thoracic Society Environmental Health Policy Committee, and I've had the opportunity to work on a lot of policy and regulatory documents in the US as related to that. That's been a really great learning experience. I'm trying to bring it more locally now. And I'm a part of the Providence Healthcare Planetary Health Strategy Development Team. And you can read about that here. I highly recommend you take a look at the strategy for Providence Health. You can join organizational advocacy groups like that. And if you're interested, I'm always happy to talk to anyone about what steps they can take. And this is just from the Providence Healthcare Strategy and what Providence is doing to address planetary health. The primary frameworks are reducing our impact, building our capacity, and developing our resilience. Please take a look. I think it's valuable reading. So to summarize the main points, all aspects of climate change have the potential to adversely impact patients with chronic respiratory disease. Climate change will have substantial cost implications for our healthcare system. So action to address climate change and adopt risk mitigation strategies is essential. Environmental injustice contributes to excess burden of climate-related morbidity and mortality in low and middle income countries, minoritized populations, low-income populations, and otherwise disadvantaged groups. And clinicians and scientists have a special role in advocating for action on climate change and air pollution. And we need to be able to communicate with our patients about exposure risks and mitigation strategies. And with that, I'll thank everyone who contributed to my portion of this research and to everyone who's doing amazing research on this front throughout the world and also contributing on the ground to community and policy efforts to address this. And I'll take any questions. Anyone online? Hearing none. Dr. Willis.
Awesome talk. I have 2 questions.
Sure.
Number one is kind of a basic question around we hear about the positive effects of sauna potentially on health. But listening to this, I'm like, well, is there a downside to sauna with those temperatures on the body and the health? That's number one. Number two, what are your thoughts on the true effectiveness of carbon capture as a modality to kind of combat some of the negative things that you've highlighted for us to look at today?
Interesting diversity of questions too. The sauna question is one I haven't actually been faced with before. So I would say that I would very much caution my vulnerable patient population, so particularly patients with poorly controlled respiratory disease, I think, or unstable cardiac disease. I think that there certainly is a high risk in those populations. So I would probably avoid extreme heat in that context. But in a general healthy population, if you're not spending like 2 hours in a sauna at one go, that's probably okay. But I don't think that we have robust evidence for it. And I'm sure that there are some reducing oxidative stress mechanism that you can look at. I don't really know that data, but it would be interesting to look at that. Yeah, I don't know. And then carbon capture and storage. I guess I do have a disclosure there, is that my sister works for a carbon capture and storage company. So I've heard a fair bit about how that technology is developing, and I think that there is a role for it, but I don't think that it is a beacon that we can rely on. The cost of it, like they're building a massive facility in Texas right now, which is going to have a lot of capacity, but it's taken, I don't know, like 5+ years to develop and billions of dollars. So expanding that sort of capacity to the level that we need it, I don't think that is a realistic large-scale option. Yes, it can be a component, but is it our savior? I definitely don't think so. Any other questions? Hopefully I didn't scare everyone into silence.
Jill, there's a question on the Zoom. Is there a difference in the prevalence of smoking in the various socioeconomic groups, which might also impact their respiratory health?
Yeah, certainly. There certainly are differences in prevalence of smoking between different socioeconomic or racial or ethnic groups. But those epidemiologic studies that I was reporting fairly consistently control for those sorts of factors when concluding the results of their studies.
Thank you.
I can't see the Zoom chat, so I apologize. If there are any other questions online, if you can speak up.
Should I be wearing masks during these smoky times, and what do you recommend?
It's very complex. I would say that a surgical mask is not useful. An N95, if you have to be outdoors and the air quality is really quite severely bad, it might be reasonable. Like if you have to be outside for a couple of hours and your AQHI is 7 or greater, it's not a terrible idea to wear a well-fitted N95 mask to reduce your total dosage of pollution that you're going to be inhaling. But practically, is that something that we can implement on wide scale for all individuals? No, I mean, like we all remember at the start of COVID, seeing the ridiculous ways that people were wearing their masks. I don't think that is going to, by and large, be a very effective solution in large scale.
Thank you.
Okay. Oh, go ahead. Hey.
So, yeah, it's like, so you talked about how models sort of like state.
Yep.
So is that sort of like a transient thing, or if it's like exposed to that kind of that?
Yeah, that's a good question. So for those online who might not have heard, it was in the mouse models looking at the pro-fibrotic effects of extreme heat. Is that a transient effect? No one's done that study yet. What we do know is that fibrosis tends to be an irreversible phenomenon. Sometimes when we see in mouse models, we're looking at models of fibrosis like the bleomycin models, they will develop fibrosis and then that fibrosis will regress. That may be a specific phenotype of mice. But when we think about pulmonary fibrosis in humans, usually once fibrosis is laid down, it is not a reversible phenomenon. We don't have enough data in those studies, though, to look at the long-term effects. Okay. Well, thanks, Sure.
So does the small, like exposure to small amounts of chemical or healthy affect the long term?
Good question. So the question is, low level PM 2.5 exposures, is there a health implication? And I would say that the data has shown that even at very low levels of PM 2.5, 5 to 10 microgram per meter cube, that there still is a significant mortality risk impact. The thing is that you can't eliminate all PM 2.5. That's a natural thing that exists in our environment. There's always going to be biomass particulates. You can't eliminate it completely. The lower we can get it, the better it seems to be for health. There isn't a clear threshold effect by and large across the entire population. So even at those low levels, there can be adverse health effects. But complete elimination is not something that is feasible. Okay. All right. Thank you so much. Okay.